It says I think it's recording now.
Great. All right, Dr. Bradley, take it away.
All right, good morning, everyone. We will go ahead and call to order at 9:02. Just a few quick housekeeping issues for the online meeting. We just advise everyone that due to public meeting, this is being recorded. Anything that you say or post in the video or chat box is part of that recording and will be displayed on the website. So just a reminder to keep yourself on mute and have your cameras off if you do not want anything shared. Again, try to keep your phone or computer on mute if you're not speaking. If attending by phone only, press *6 to unmute yourself. Shelley and Julia will be monitoring the chat box for questions. And for everyone's benefit for the online format, if you could please identify yourself by name before you state your remarks so we can capture who's speaking for the records. Again, we thank everyone for being patient with this continued virtual format. I think it's one of those things where it's not ideal, but at least gives everyone the opportunity to still meet and keep our work going. Shelley, we'll go ahead for roll call, please.
All right, Andrew Tang.
Present.
Brent Burgett. Chris Salvino. Clifford Jones. David Notrika. Debbie Johnston.
Here.
Bronco Castro-Marin.
Here.
Gail Bradley. Garth Gamer.
Present.
Herman Butler.
Present.
Ayman Fizervan.
Present.
Judy Baum.
Present.
Melissa Anderson.
Present.
Neil Williamson indicated he would be absent. Nirav Patel.
Present.
Philip Johnson.
Present.
Rodney Reed.
Present.
Sandy Nygaard. Sharon McDonough. Sean Bowker.
Present.
Tara Johnson.
Present.
And Vicki Bennett.
Present.
We have 15. We do have quorum. Thank you.
All right, thank you very much, Shelley. Next up on the agenda, we have the attendance report that is in your packets that were provided electronically. If you can please review your attendance. Hopefully with the electronic format, it does provide people the opportunity to attend. Just a reminder that if you do miss 2 consecutive meetings, you will get contacted by the Bureau to ensure you still would like to participate. We do have some vacancies. We wanted to first recognize and thank Jeff Vargas, who has been a longtime member of this committee. He has recently retired and tendered his resignation as a part of STAB. So just wanted to thank him and recognize him for his participation over the years. Some other vacancies include for statewide Fire District Association representative, which is what Jeff has retired from. Next is representative from a federal Indian Health Services organization. To apply, please submit a letter of interest and updated resume or CV to Shelley. Roles are appointed by Director Chris and terms to this committee are for 3 years. Next up, I wanted to briefly talk about the Naloxone Leave Behind program. This is something that we're really trying to get the message out across the state of Arizona. We've definitely had an issue with continued opioid overdoses over the last number of years. We've seen the trend both in Arizona as well as nationally of increasing opioid overdoses over the course of the pandemic. As COVID is hopefully winding down, there's still a number of financial stressors and psychological stressors related to the pandemic. And unfortunately, we don't see a decrease in the trend of overdoses. One of the pieces that has been implemented as part of the Arizona program, as well as across the country, is naloxone leave behind. For those on this committee, I'll just very briefly describe what that is. It's a program where EMS providers can essentially dispense or distribute naloxone to patients or families or friends who are at risk for overdose. So if they're on a call or someone comes up to them and they're in this program, they can essentially distribute a naloxone dose to that individual. We do have the opportunity to provide free naloxone. There's two formats through the Center of Rural Health. That's one option. It does require some additional training through that program. The other option is directly through Arizona Department of Health Services, Office of Injury Prevention. Through Jackie Kurth and her office, we can provide that information as well if anyone is interested. That is completely free, and they are willing to provide naloxone to any EMS agency that would like to implement this program. We do have a letter and that's from the Bureau that essentially outlines this process, if anyone has any questions, but just really wanted to spread the word regarding naloxone leave behind as we see the opioid epidemic continue. Any questions or comments about that program? All right, hearing none, I will go ahead and transfer this over to Chief Garcia for the Bureau report. Thank you.
All right, how's my audio?
Can you guys hear Chief Garcia okay?
Good morning. Can you all hear me? How's my audio?
Yeah, we can hear.
All right. Well, in honor of EMS Week, we wanted to start out by thanking all of our EMS providers that continue to serve on the front lines. We appreciate you. I want to touch on some staffing transitions first. As you all know, we have several positions that are currently vacant. The state jobs website is updated with some of the Bureau positions that are currently open and accepting applications. We still have the non-regulatory services section chief position, formerly held by Ben Fisher, that remains vacant. And we're also working on adding a position that will be focused on health equity and public health initiatives moving forward. Some updates from the Bureau. We continue to share Gov delivery bulletins and have been sending those out at least on a monthly basis. I'm sure many of you have seen this information already, but after surveys and discussion with some of our stakeholders, the Bureau is preparing to transition to a fully online certification process that will include the issuance of digital certification cards as of July 1st. We'll have more information available on our online services website as we approach July 1st. There was also a CMS waiver recently released that allows for Medicare reimbursement for treatment in place. That is retroactive back to March 1st, 2020. We've also shared that new legislation has been signed that ensures that Arizonans acting in good faith during the pandemic are protected against civil claims. This Senate Bill 1377 replaces the former Good Samaritan executive order and ensures protections in place for our EMS and trauma system workers. Most recently, the Administrative Order 2020-15, which provided limited EMS rule waivers, did sunset on March 31st, 2021. So our limited rule waivers are no longer in effect. Those have ended. Still though, Emergency Measure 2020-05 continues to authorize all levels of EMCPs to administer both vaccinations as well as viral testing. We expect that emergency measure to stay in place for up to 18 months so that EMTs can continue to administer both testing and vaccinations. We'll keep our ADHS website updated with revised EMS provider guidelines and information related to COVID-19. We also expect the Arizona Surge Line to remain in effect moving forward. They continue to provide both consultation to providers as well as facilitate transfers as needed. I want to add in that we apologize for a delay, but we're still waiting to confirm our appropriation for regional councils for the upcoming fiscal year. We expect that funding will return to the level it was at in 2019 for our regional councils, and that will be without supplemental grant funding. But we'll keep you all updated on that process as we wait to learn our appropriation and realize that this is quite late in the year to learn that. Some rule updates. For Article 5, ADHS has submitted an exception request for exempt rulemaking, and that is to update our EMS scope of practice, that Table 5.1, to be consistent with best practices and national standards. Based on those recommendations from our Medical Direction Commission, there's been no record of approval yet from the governor's office. We expect there will be a public comment period prior to adoption, and we will certainly keep the committees updated on the progress related to scope of practice updates. On Articles 9 through 11, the department continues to seek stakeholder feedback, as you know, on ground ambulance rules. We encourage you to visit the website for some of our upcoming rule work group information. The next ground ambulance rules meeting has been rescheduled for June 23rd, and we're currently seeking feedback on ground ambulance rules through a survey that will remain open through June. Per our administrative council and rules, there are at least 2 definitions that we are looking for additional feedback on. And so if any committee members are interested in providing feedback, they can certainly respond via that survey that we have open or provide comment during the public comment section of this meeting. I believe Ruth Ann has joined us and may have some additional information to share during that section. The last thing I'll share is for other items or questions related to blood products or pathways for trauma center designation, we'd like to encourage stakeholders to reach out to us, and we can certainly discuss more in these statutory and standing committee meetings. Thank you all again for your service. That is the end of my report.
All right, thank you very much. I did want to acknowledge there is a message that Vicki Bennett put in the chat box. And I think we were definitely remiss in not recognizing that May is also National Trauma Awareness Month. And as part of this national recognition, days have been set aside to recognize Trauma Data Professionals Day, which is May 5th, Injury Prevention Professionals Day, which is May 12th, Trauma Survivors Day, which is May 19th, and National Stop the Bleed Day, which is May 20th. So thank you, Vicki, for pointing that out. Today is May 20th as well, so it is the day of recognition for Stop the Bleed. So big thank you to pointing that out, and we appreciate that. In addition, in the chat box, there is a link for the Office of Injury Prevention to order the Naloxone that Julie Benton has shared as well. So if you wanted to go to that link directly, that is available in the chat box. So thank you, Vicki. Next up, we have Vatsal, who's going to present opioid and out-of-hospital cardiac arrest data trends.
Good morning, everyone. So it's the same report which I've been presenting. You guys can hear me well? Sorry.
Yes, you sound good, Vatsal. Thank you.
So this is cardiac arrest, and now I have included a year 2020 to it. So the pink bar is 2020, and it is it's going from January to April, and then rest of the months, then it goes back to again last 3 years of the data. So what we are seeing over here in that pink bars is that the cardiac arrest incidents are still on rise, especially like January, we saw a big jump. Then February, the incidents are again increased compared to the last February. Same for March, a little bit increased, and April kind of a little bit increased than last year. So we are still kind of seeing the same trend of increase in the number of cardiac arrest trends. That the percent-wise, again, it's the same thing. We can go to the next graph. Thank you. The disposition cardiac arrest, I think that let's go to the next graph, to the transport first. I think that's interesting, that how many people are getting transported, and what we are seeing is that it's lower compared to what we have seen in the previous years. So last 2 years, if we see 2020 and 2021 is kind of lowest compared to the previous 2 years. So again, the trend has continued that the number of transports has decreased compared to pre-COVID. Can we please go to the opioid now? Yeah, the opioid incidents, there is a slight increase. They are in the range of 900 cases to 1,000 cases per year. That's what I am now seeing. That's what, like, in 2019 and 2020 and 2021, we are what we are observing is that around that much, anywhere between 900 to 1,000 opioid overdose cases, suspected opioid overdose cases, we are seeing it per month. And next slide, next one, please. And the number of deaths. So around 4%, there is a slight increase in the number of deaths, but I don't think so it's significant. But the trend is continuing. The number of deaths are increasing, but more than that, number of opioid overdose cases are staying at around 900 to 1,000 cases per month. I think that's about it. Dr. Bradley, if you have any comments on this.
No, thank you very much, Vatsal. I appreciate that. Are there any questions or comments from the committee members or the public regarding this data? All right, hearing none. Thank you, Vatsal. We appreciate it. I think it's really good information for us to continue to monitor as kind of the ongoing effects from the COVID pandemic. Next up, we are going to go ahead with standing committee reports. We'll start with Sean with the TEPI report, please.
Good morning. Can everybody hear me?
We can, thank you.
Thank you. So the meeting was called to order and by Vice Chairman Melissa Moyer. A quorum was established and the minutes were approved. The chair report, and during the chair report, we welcomed new members, Deborah Burkett, Allison Welch, and Jacqueline Kurth. And we also announced the retirement of Pam Gosler. Dr. Gosler has served the state and various trauma committees and injury prevention for many years, and we appreciate her service. There was one vacancy announced for Air Ambulance Premier EMS Agency Quality Improvement Officer. And then Chief Garcia gave an update on EMS rules activity and reminded everyone to check updated governmental orders that are posted on the AZDHS website. The update was provided on the STAB blood products work group, and at that time there was another meeting scheduled. There were updates provided on the naloxone leave behind program, and on there was also a brief presentation given on that by Dr. Glenn. And then Ms. Benton gave updates on the SHARE program and on EMS for children. There is trach training that has been developed that is going through the process of approval on PACES, and also adverse childhood experiences training was placed on the website. And then Mr. Chacana gave updates on data dashboards that are available to the public, and Ms. Vosbrink gave updates on the Premier EMS Agency's program status guide using validation scores. We also discussed discretionary report sequencing, and no reports have currently been generated, but data has been shared regarding COVID, cardiac arrest, and opioids. The drug updates, the retirement of Mary Bankert was announced, and we welcomed Carissa Wilson to the group. And there were no updates from the Trauma Program Managers Work Group or MSRUG other than the next meeting. And then the next meeting for TEPI will be on July 15th. And the meeting was adjourned at 9:34. And that's it for the TEPI update.
All right, thank you very much, Sean. Next up, Sandy with Education Committee update. I do not see, Shelley, did you see if Sandy had joined us today?
No, I don't. I think she's absent today.
Is Amber Rice? I saw her on the line earlier. I'm not sure if she's able to give an update.
Sorry, I'm in the office here with Josh. Which committee update?
For
Oh,
education. Yes.
Oh, yeah. So for education, we just have the two work groups that we've been working on. There was is the LVAD work group and the Leave Behind Narcan training that was created that'll come through the committee on the next go around for approval. And on the last education committee meeting, we approved the PACES education that was put together, or the PEDS education that was put together by the PEDS group.
Excellent. Thank you very much, Amber.
Yep.
Next up, Franco for PMD report.
Good morning, everyone. The PMD committee was called to order on March 18th. We received a bureau update from Chief Garcia and Dr. Bradley. The major items that I can summarize are that we got an update from Dr. Bradley discussing the 2021 update to the NASEMSO EMS model EMS clinical guidelines. And Dr. Bradley gave us some background and time frame for these materials. This will then feed into PMD to update the state model guidelines, the T3Gs as well. We got an update from Dr. Rice and the team from the U of A on their creation of a curriculum for an Arizona-specific CPR training, high-quality CPR and ACLS, with the creation of curricula and training, as well as train the trainer. We heard quite a bit about that program. We heard about the, I'm just finding my place here. We heard more details on the from Dr. Glenn about the Naloxone Leave Behind as well, Leave Behind program that was mentioned at the top of this meeting as well. Those are the major highlights from PMD in March. Thank you.
All right, thank you very much. Next up, Kara Mitchell for Trauma Managers Work Group update.
Hi, everyone. So our last trauma program manager work group meeting, we discussed the ACS's site visit, the changes in their site visits, and then the state talked about how that's going to change the state's perspective of coming out for our site visits. We also had a large open discussion about our COVID-19 mitigation in regards to changes in our injury prevention activities and how we can still be doing these activities and meeting the requirements for state. And it was a really robust conversation with lots of ideas from multiple different centers. Our upcoming meeting is scheduled for, double checking my calendar here, Friday, June 25th. Our invite was sent out this week. And at that meeting, we're planning on discussing, we'll have a bureau update, status of mask policy changes, and then we'll be talking probably more about state visits and ACS site visits and the changes that have come with those. And that's it for us.
Thank you very much, Kara. Next up,
Dr.
Julia.
Bradley?
Oh, yes, go ahead.
Yeah, this is Garth Gamer. Probably a question for Kara. This came up at Ames yesterday regarding this ACS site visits, and it sounds like they're going to be completely virtual for the foreseeable future. How long is that foreseeable future, and do you anticipate them ever going back to in person?
That's a really good question that I think all ACS centers would really like to know the answer to. I believe the last time I've gotten an update, the last time I've heard it, it was that this isn't necessarily a forever process, but I think the interpretation that most are getting is that they're probably going to stick to a virtual format moving forward, but move to an in-person format for new centers looking to get first-time ACS verification.
And then I believe the state is actually going to do in-person site visits coming up or starting soon. Is that correct?
Yes, I think that is our understanding as well.
Thank you.
Absolutely.
All right, thank you. Next up, Julia, for PACES report.
Good morning, everybody. Just a couple of updates for PACES. Currently, we do have one vacancy on the committee for an emergency physician. We recently approved the tracheostomy training in partnership with the education committee, so that is currently on the website for use. We are also working on a set of questions that can be used for as like a post test, and that will be posted when that's completed and approved at the next PACES committee meeting in July. For upcoming projects that were discussed at the last meeting, we do plan to work on a training for naloxone for pediatric patients, as well as something to address pediatric behavioral health. So those will be on the agenda for the upcoming meeting in July and addressed accordingly. Lastly, thank you to all who participated in the National EMS survey as part of the EMS for Children program. We did get responses from over 75 agencies, so that's awesome. Currently, we are in the midst of the National Pediatric Readiness Project assessment. So that is an assessment of hospital pediatric readiness. So information about that went out to hospitals over the last couple of weeks, and we will be promoting that through the end of July. That's all.
All right, thank you very much, Julia. I appreciate it. We are going to do just a little bit of a change on the order for the agenda because Dr. Gaither has to be done by 10 o'clock. So we're going to come back to the minutes a little later, and we're going to just discuss the information on field use of blood products from the blood product work group. So I'm going to turn it over to Josh for that discussion and presentation. Thank you.
Perfect. Thanks, Dr. Bradley. Thanks for accommodating my somewhat dynamic schedule today. So if you all want to pull up, I believe it's attachment 6 to the agenda for today, which is the product of our work group. I think important to note as we look at this document, this is an informational only document. It's not meant to change the scope of practice or change guidelines. Those types of actions would have to go obviously through the PMD MDC process. So we sought to address several specific questions in this informational document. The first one was who can administer blood products? And as you all, of course, can read faster than I can talk, you can take a quick look at those. We did divide it up into those individuals responding to 911 calls and those individuals performing interfacility transports. The reason for this division is that obviously the drugs allowable are different for those two types of calls. I think I'll continue on and answer any questions about the whole thing at the end, as that tends to do a little better in this virtual format. The second question we talked about was which blood products can be administered. As you can see here, the DHS does not regulate the type of blood products. It uses the generic statement blood products. So that would be up to the agency to determine what should be administered when it is allowed to be administered under a specific situation by a specific approved provider. Question number 3, which blood product should be given in the pre-hospital setting? This was put in here mostly for informational purposes for those individuals who may be looking to develop or considering implementing a blood product program. We simply list out here the different options. Whole blood provides some advantages and disadvantages. Packed red blood cells, similarly advantages, disadvantages. FFP, platelets, and cryoprecipitate. We did include in here for platelets and cryoprecipitate, not recommended for field use unless part of an MTP, massive transfusion protocol. Next, we went on to address should pre-hospital transfusion programs consider RH factor typing. So you can read this statement here. RX factor typing is important and should be considered. However, there are some other options when it comes to managing undifferentiated patients in the pre-hospital setting where obviously RH factor typing is not possible. We list the best to worst options here. Best option, any blood product that has been matched to the patient's blood type, obviously applicable for those inter-facility transports. Second best option, O negative or O positive negative if it is a male. And alternatives, mentioning the low titer O positive blood as an alternative. However, we are still awaiting better evidence on the safety of that as an option in the pre-hospital setting. Moving on then, the next question we addressed is, are there guidelines for implementation of a pre-hospital blood product program? We wanted to be very clear here in that the Arizona Department of Health Services only regulates EMT scope of practice, and that there are no current AZDHS requirements or guidelines that EMS agencies must abide by when implementing a blood product program. This information we provide in this section below is for information only, and not intended to be a guideline or change in the scope of practice. So first recommendation from the group is that pre-hospital blood product programs should avoid waste of blood products. And you can see the recommendations there. Ensure blood products are stored appropriately, ensure temperatures are monitored, and ensure that there's a written plan to prevent waste. Number two, pre-hospital blood products should aim to optimize the benefits and minimize the risk. You can see here, EMS agencies should implement clear guidelines/policies to ensure appropriate use. Obviously, guidelines and protocols regarding administration of blood products should include criteria that limit administration of blood products when time to the closest trauma center is short. EMS guidelines protocols should require that when blood is given in the pre-hospital setting, administration of the blood product does not increase the prolonged scene times have been shown to increase mortality in trauma patients, and providing on-scene blood should not increase those on-scene times. And then obviously, agencies should have a strong quality improvement program to review every use of blood. Finally, blood product programs should implement a comprehensive severe trauma care program. I think the key concept the committee wanted to get across here was blood is just one part of a patient care package. And if the basics are not focused on or neglected, implementation of a blood product program will likely not improve outcomes. Focusing on IV access, hemorrhage control, following evidence-based guidelines for trauma care is critical. Finally, the last question is, when should blood products be given? Pre-hospital blood product programs are an area of rapidly evolving medical science. At this time, there are no widely published evidence-based guidelines or standards of care to guide when blood products should be administered. This is really punting down the road a little bit as there's limited evidence at this time. So with that, I will just refocus on the key and critical components here. This is an informational document. It is not meant to be anything more than information. So with that, I'll open it up to questions, comments.
Dr. Bradley and Dr. Gaither, can you hear me?
Yes, go ahead.
Oh, okay. Yeah, this is Garth Gamer. First off, I want to compliment Drs. Gaither and Bradley for their work on this. It's a great document. Furthermore, you did a great job keeping the group with multiple opinions and vocal opinions at that on point for this document. So I wanted to recognize you two. Just a couple things. I think that, and we talked about this in committee, that the guidelines on the last page, the second point there, the guidelines regarding pre-hospital administration of blood should include criteria that prohibit the administration of blood products when the time of closest trauma center is less than 15 minutes. So I think the term prohibit kind of limits us, and I'll try and explain why. If a person needs blood and blood's available, and there's a an entrapment situation or extrication, excuse me, situation that you kind of don't know what the endpoint is, but you could still potentially administer blood to a profoundly hypotensive individual. And you could be just right across the street from the trauma center. And I think that this criteria kind of limits us. And if I could offer some wording to maybe consider that, take out the words prohibit the and maybe limit to special circumstances. And then you could even define those special circumstances. But I was wondering if that would be accepting of you and the committee and the trauma board here. Also, one other technical thing. You mentioned TXA, which is kind of not in the scope yet. I fully agree with that as a potential addition to scope. But there's just that one little technicality I wanted to point out. Thank you.
Thank you, Dr. Gamer. So I think this is really just kind of a brief discussion and informational document. So this is not going to get approved or voted on at all by this committee. It was really just an informational work group. So it really was more to get the conversation and kind of obtain the lay of the land in regards to the current setting of blood products. So for the STAB perspective, there isn't the ability of STAB to kind of vote or make any specific statements on this document. This is really just purely informational and to get the discussion out, if that makes more sense.
So I don't know, is that something that you want to take back to the Bureau and discuss perhaps between you and Dr. Gaither, if that would be an acceptable change?
So I don't think the plan is to publish this document. It's not a guidance document. It's just really was information provided to this committee. So I think as part of that information, the verbal discussion that you've provided, I think are excellent points. So it's nothing that's going to be published to the website or guidance documents. I don't think we would need any formal decision or vote to change or alter the document at all, if that makes more sense.
Understood. Thank you.
Thank you. So really the goal of this is to just kind of start the conversation as some states are starting to implement blood products in the pre-hospital setting and just really to get a consistent messaging across the state of what is currently allowed. There have been questions that have been raised by different EMS providers across the state of what is or is not currently allowed. And so we try to address that with this work group. But really, this is the opportunity for us to kind of gather information and then bring back to this committee as trauma experts from the state to have further conversation. Is there anyone else who'd like to speak up and make a statement or comment?
Hey, Gail, it's Nerve. Just a quick question directionally, and I see where you're going with this, right? A lot of work put into this document, right? A lot of it is a guideline to your point of what other programs or what the state may look at doing with this. If we don't even make it accessible, even just as a guideline, to be able to even get further comments, how will all this work help us for programs trying to move forward in the state, trying to move forward as we try to get our hands around blood products?
So I will say, I believe Ethan is on the line. Ethan, I'm not sure if you can speak to kind of the guidance document process in regards to a pilot project. So for something to become a pilot project, that would, the Bureau is still trying to kind of develop a system and process to actually implement pilot projects if that were to be the option. The other option is to look at and propose something to be added to the drug table or scope of practice. The drug tables would be proposed through the PMD and MDC pathway. Scope of practice, we are still a little bit in limbo with that process right now. There is a current version that was approved at EMS Council and MDC that we are waiting on at the governor's office to kind of move forward. But I don't know, Ethan, if you're able to maybe speak about the guidance document option.
Sure, Gail. I'll take a moment just to cover it really quickly for everyone. So guidance documents are used as a form of explanation for rules where they may not be clear. Rules are generally used for guidance when statutes are generally not clear and there needs to be more detail added to them. So while rules have the force of law behind them, guidance documents are just that, they're guidance. While they're helpful, they don't have much more substance to them than a recommendation or just general guidance. And so what it sounds like being discussed, and I should add, the other type of guidance document that we're able to issue is a substantive policy statement. This doesn't sound like a substantive policy issue for the simple reason that policy is usually generated by the Bureau on certain issues that have to be addressed. This sounds more like a best practice issue, a best practice subject, what everyone thinks should be the standard in Arizona. And I think that's going to require more discussion and more input from all the stakeholders, because it sounds like it's both a rural issue as well as a urban issue. And it sounds like something that should be discussed and then a decision made by a number of different groups and people as to what should be done with this. So guidance document, while it may be helpful, may not be the best course on this. It may require a rule change. And if that's the case, then you're definitely going to need more information.
Dr. Bradley, if I could just add one comment from the work group's perspective. I think for the group's knowledge, it is very important to realize that the goal of this document was to explain what's currently allowed. And if we go back up to the top of this document, you'll note that under current rules, only nurses responding to 911 calls and interfacility transport paramedics can give blood products. That's the reason that it makes sense in this informational setting to include the timelines such as 15 minutes and include TXA, which obviously can be given by a nurse who is performing a 911 transport by air in a critical care transport apparatus. So hopefully that adds a little clarity to kind of the group's thought process on why those two items were in there.
And Dr. Bradley, this is Sean Bowker, and I just have one other comment. I think it's important, at least from my perspective and probably from the group's perspective, to be mindful of the very limited supply of blood product. And so if we say down the road, 5 years from now, all EMS agencies at scope of practice and they can carry blood, it's a very real concern that the demand may outstretch the supply, and then the trauma centers would not have enough blood to administer to patients. So we need to be very mindful of our current inventory and ability to get more blood.
Thank you, Sean. So any other comments or questions? Really, our goal was to start this process and really start the conversation in Arizona. I don't think we've discussed this prior to this meeting in any depth at any of the standing or statutory committee meetings. And so I think it's a really important conversation as we start to see some data coming out to support it. So this is really kind of step one in this process, is to really get the conversation going and to also let people understand what is currently allowed. So that was really part of the thing we wanted to make sure abundantly clear to everyone. There are settings where pre-hospital blood can be administered currently in Arizona, but just to get that information and have this as a starting point. Any further questions or comments? All right, hearing none, a big thank you to Dr. Gaither and all of the individuals that participated in the subgroup committee. We had really good discussion there as well, and I think this is a great first step. So thank you again. Next up, if I can get a motion to discuss and amend and approve the staff meeting minutes from January 21st, 2021.
So moved.
Thank you. That was Sean for first and Garth for second. Any amendments recommended by the committee? All right, hearing none. To help make this a better voting process compared to the last time around, we'll start with any nays. Is there anyone that does not approve the meeting minutes from January 21st? Please speak up. Hearing none. Any abstentions? Hearing none. All those in favor, please say aye.
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 All right, meeting minutes are approved. Thank you very much. Next up, we are going to continue our kind of research and educational topic presentations. We are going to hand it over to Dr. Dabrowski for a brief presentation of whole blood and trauma.
Thank you. Let me see if I can load my slides.
All right, I see it coming up.
All right. So this is just a brief 1 hour presentation on whole blood. I'm just kidding. Whole blood, something new and different, I believe is why we're having this discussion. And I say new and different with tongue firmly in cheek. Here's the obligatory history of blood transfusion slide that goes over kind of initial attempts at blood transfusion. Didn't go so well until the ABO compatibility issues were identified and understood better and by Dr. von Steiner back in early 1900. It was an American, Ruben Ottenberg, who was the first to suggest that the patient and donor blood should be cross-matched before transfusion to look for compatibility. Trauma plays a key role in the advancement of transfusion technologies and processes, looking at First World War and the anticoagulants and refrigeration that were able to prolong the shelf life and preservation of the blood. Second World War, certainly it was used to a great extent, and there were lessons learned that had to be relearned from the First World War. And even the Korean War, when blood began to be stored in essentially the plastic bags instead of the glass bottles. And you know, whole blood is up until the late 60s, early 70s was the blood we were talking about. There wasn't the separation of components like what we have now. So the term "back to the future" plays a key is a key phrase in many of the discussions regarding the new use of whole blood, which is, of course, something that has been used since blood transfusions began.
I'm sorry, the slides are not advancing.
Sorry?
The slides.
The slides are not advancing.
One second.
Go to slideshow, and then that should allow you to do that.
I see what I'm doing. I'm actually doing the slideshow in the hang on here. Not. All right. You can see this.
Yeah, balanced trauma resuscitation is visible.
All right. Well, I'll leave it in this format and just be able to advance it. You can see the balanced trauma resuscitation slide now?
Yes.
That's what I'm looking at. All right. So whole blood is, again, something that's been used for years. In the late 60s, early 70s, went to a component separation situation. And but we've learned, certainly in the last 20 years, that for trauma patients who are bleeding, it is essentially whole blood, or something as close to whole blood as possible, is more effective and better at controlling coagulopathy, correcting coagulopathy than what we had done previously. A lot of crystalloid, packed cells. So we talk about the 1-to-1 ratio of blood cells to plasma to platelets, and we've learned over the last 20 years that it's probably a 1-to-1-to-1 or a 2-to-1-to-1 ratio that's going to be the best for our patients, and it has been found to improve morbidity and mortality in the injured patients. But the problem is, even when we take those components and we mix them together, it will that mixture of platelets and packed cells and plasma is inferior to whole blood when you look at hematocrit and platelets and coagulation factors. I am having a hard time advancing.
Whole blood benefits is visible.
All right, thank you. I cannot see whatever both screens. So there are certainly benefits, as already mentioned, benefits to the whole blood, higher hematocrit, coag factors, and platelets. Certainly, the simplified logistics matters as well. Instead of having to give numerous component bags, a single bag that has platelets and plasma and whole blood, and packed cells in it, it simplifies what is going on during these active resuscitations. There's also the misconceptions in regards to the use of whole blood that had to be overcome as well. And early on, it was thought that type specific was really the way to go, but it has been found to be safe for group whole blood that can be used as a universal donor. The issue with the antibodies is certainly because plasma has antibodies in it, that they look for donors that have a low titer of those antibodies to be so that way there is less chance of a transfusion reaction, and those transfusion reactions in the literature have been quite low. The whole blood can be leukoreduced, and there are platelet-sparing filters out there for the use. And it also has been found that it can be stored refrigerated and keep its factors relatively strong for at least a period of 14 days. And when we talk about trauma resuscitation, we know that when patients need blood, we need to get it there quickly. And this is every minute counts. This is just some information from the proper trial, looking at timing of blood availability for patients who need it, and found that it does matter. But so people have been looking for comparisons between whole blood and component therapy, and so far there hasn't been evidence that whole blood is superior to component therapy. Here's a study from 2020 looking at this comparison, and they found that whole blood was not associated with a 24-hour or in-hospital mortality. Also, in 2021, another trial and a systematic review did not find any survival benefit between whole blood and component therapy. So this, we are still looking for evidence that whole blood will make a difference. It has been brought to the pre-hospital scene, and there's a group that's done a lot of that research in San Antonio, and they looked at they looked at a single air medical organization to see about their patients and the ability to get blood to the patients in the scene, and what percentage of the patients potentially could benefit from the blood. And it was it's quite low from what they found, and they obviously identified a lot of logistics issues that they needed to overcome as well. They've also looked at deploying this low titer O positive whole blood into their area, essentially the greater San Antonio area, and have had great buy-in. They've had numerous air medical bases, as well as 12 EMS agencies, ground agencies, and a level 1 trauma center, and even a level 4 trauma center that's been involved with the use of whole blood beginning at the scene. And essentially no data yet. This is from January 2021. No data yet on finding that that deployment at the scene has changed outcomes. In summary, essentially, looking at the literature, the data is incomplete. Although there are benefits for using whole blood, things like logistics and things like that, there has yet to be identified a survival advantage with the use of whole blood over component therapy. And certainly whole blood is becoming more common, used in trauma centers. And during this crazy year of 2020, both Vitalant and Red Cross here in Arizona have now made whole blood available, at least to the trauma centers for use. And again, across the United States, whole blood is now starting to be used again by both ground and EMS units. I'm aware of Seattle, certainly San Antonio. I know blood was available. I'm not sure if they actually moved to whole blood, but they had component blood available up in Minnesota, and certainly other places are moving to use whole blood for trauma. Thank you.
Thank you very much. It was a very informative presentation. So, any questions for Dr. Dabrowski?
Paul Cliff Jones, that was a great presentation. Another one has been UT Herman, and I think the entire city of Houston's been really moved to this probably almost 3 or 4 years ago as their mainstay.
Yeah, certainly. I know they use it in the hospital, and Brian Cotton, who I used to work with, has been instrumental in all things blood, from coagulation factors to whole blood as well. Nice to hear you, Cliff.
Excellent. Any other questions for Dr. Dabrowski? Thank you again for that presentation. We hope to continue these at these meetings, have at least one presentation, either on topics such as this or a research presentation that you may be doing in your institution relating to trauma and EMS. So we appreciate the information sharing as part of STAB. That does lead into our next topic, which is discuss future STAB projects and agenda items. This is one of the things that I really, when I came to the Bureau a little over a year and a half ago, I really wanted to find a way to make this meeting hopefully more informative and useful in terms of what we can provide to you as the committee members. As part of statute, you are kind of the body that advises the state and the Bureau on trauma-related activities. And so we really want to make sure that we are providing good reports as part of this. So one of the things that we are going to kind of continue, and I wanted to get some feedback. We did have the ACS Committee on Trauma Chair report back in January, is how frequently does that group meet and how frequently should we have that on the agenda? Don't know, Dr. Patel or Dr. Tang, if you can speak to that.
I think I'll leave to Dr. Patel to answer, as he's the chair of the Arizona chapter.
Sorry, Dr. Bradley, I missed that question.
Oh, not a problem. I was just asking in regards to how frequently the ACS COT meets and how often you would like to provide the report to STAB.
The ACS COT board will meet on a biannual basis, once during the ACS Arizona chapter of the American College of Surgeons, and then there'll be another virtual one. I think with as dynamic as things are right now, especially as all the questions raised with respect to verification and all the other educational programs that are trying to figure out how to do a virtual hybrid model, I would probably say have the next update in the next quarter, and thereafter I think it could be every 6 months. Just
Perfect.
A recommendation.
Okay, thank you. We will, I believe, Shelley, the next meeting for STAB is in September. Is that correct?
Yes, that is correct. It's September 16th.
Okay. Thank you. So we will make sure we have you on the agenda for September 16th meeting. So some of the other topics we had prioritized previously, having a military report. I know that there are many military partnerships throughout Arizona with EMS and with some of our trauma centers. So I just wanted to see if there's anyone that would like to maybe talk about their program or partnership that they have. Otherwise, we can potentially do some background work on that as well. Any further discussion regarding STAB projects or agenda items? All right. Next, we will move to agenda items to be considered for the next meeting. So a little bit of follow-up on that. To Dr. Patel's point, and I think the questions that were raised previously under the Trauma Program Managers Work Group, we will definitely add to the formal agenda for next meeting an update or at least discussion regarding the ACS and state pathway for certification for trauma centers. We will make sure we cover that topic at the next meeting. I do believe we have our data presentation ironed out for next meeting. Is that correct, Shelley?
Yes, it looks like COVID-19 impacts and learnings from a trauma perspective.
Excellent. Okay, that would be a great presentation in September. Is there anything else that the group would like to have added to the agenda for next meeting? You can either speak up now or feel free at any point to email either myself or Shelley, and we can make sure we can get those added to the agenda. All right, next is call to the public. All right, summary of current events. If you can scroll down just a little bit, please, Shelley. These are displayed in your packets that you received electronically. There are the live links, which should take you to each of the individual conferences, both EMS and trauma related. We also have the Bureau's website, which includes updates as well. Our next meeting will be September 16th at 9 a.m., likely a continued virtual format, although that will be determined probably closer to the event. Can I get a motion to adjourn?
Motion to adjourn.
Thanks. I think it was Andy. All right.
Second.
Thank you, Garth. All right. Meeting is adjourned. Thank you, everyone. And we will see you next meeting.
Thank you, Dr. Bradley.
Thank you.
Thank you. Bye-bye.
Thank you. Happy
Thanks
EMS
all.
week.
Thank you.